nurse here. I'm someone that's, oh, there's a bit of an echo. And it's really always happy for me to just have this conversation. So taking the stock in regards of the global nursing workforce from 2018 to 2023, and this I adopted from WHO, we are able to see the numbers of the nursing, see the millions, 27.9 million, and its distributions within the Africa region is 1.7 million nursing personnel. And you also see the 14.1 nursing personnel per 10,000 populations. So we really need to be able to grow from our current numbers and projecting. We've grown, and we really want to appreciate what we have been able to do over the years in regards of increasing the numbers. But again, going in regards to its distributions, and you see we still has a 2.6% lower density compared to the rest of the world. And you see within the African map and its distributions, we are still less. We are still not yet there. So checking on this, we are 13% of the global average, and we still have very, very few numbers that we need to be able to think through. Okay, so the 27% of the health workers in 10 countries are unemployed, and this was the nursing report within the Africa region, and you are able to check on the total unemployed, the nurses and the midwives themselves, and the estimated unemployment rates, which is at 26.6%. What does that mean? We need to be able to bring those who are unemployed before first we talk about the shortages that we are looking as we go to the future. So the 55.6% of the health workforce are unemployed among the nurses, and 10% of the skills per year that we always lose them because they will not be able to finally get their jobs. So moving closer to the projections within the region, and we are looking at the supply versus the need for the nurses within the Africa region. And this is a projection between 2022 to 2030. And in this projection, we are able to see that we aren't there. As for now, in 2025, we need to be able to move to meet our targets in 2030, which we are still not there. We need to perhaps increase every year in regards to the numbers. And we are going fast to the production, and we are trying to match the production versus the supply. And where we are not being able to reach in regards of coming up with the projected numbers for the supply and seeing the various scenarios. So the worst case scenario is that by 2030, we should be able to have around 4.5 million, yet our projection is at 6.2 million. Being consistent with the resources we have and also moving and checking where we are in the future. So to catch up with the global demands, those estimates, 18 million shortages of the nurses by 2030. This is the nurses and midwife reports. So this is the reality. And for that, we need to be able to have over 39 million nurses shortages by 2030. So we are able to actually check the disease burden in Africa and checking on the effective interventions along our life course and how do we need to be able to reach where we are. So as a continent, which I love much, a lot needs to be done from the production and also absorption in the employment. So coming closer home to Kenya, this is how our health systems, and this is basically for us to be able to appreciate, we start from the community levels and we go all the way to the national referral hospitals. A quick picture of where we are based in Africa, that is where we are within the East Africa. When we talk about the community level, what will be the building blocks for us to be able to receive the services? If you are in the community, and for example, Edna is in a village in part of the Kenyan landscapes, I may live from the community level. I go to the primary health care, that is the health dispensary. I go to the referral hospital, the secondary and the tertiary. But I can also start from the community and just work to our national referral hospitals and the primary health center. So this is how the referral patterns goes, how we will be able to cover the entire all levels within the healthcare system. So picking up on the health workforce, we did the nation as part of the team on the health labor market analysis report for Kenya. And in this health workforce analysis, it shows the distributions. And this is not something unusual from us. Mostly the nurses are the ones who are many compared to the medical doctors, other health professionals, the clinical officers, and the pharmacists. So our nurses are around 65%. And when we also check on this graph, which is there, you are able to check on the projection of the number of nurses for both who are bachelors in nursing, that is the degree, the registered nurses, the enrolled nurses. And comparing with all the entire workforce, we still have a bit of numbers, and we've seen the growth from 2010 to 2020. So when I worked in the council from 2015, and by the time I left in 2023, we noted that we actually doubled the number of training facilities. So we had 55, and by the time around 55, 60, and right now we are almost around 130. So even doubling it has also doubled our numbers, but we're still not yet there. Remember my previous slides when we were just talking about the numbers and the projections and where the future we need to be able to go. So checking on our workforce. So we have a bit of discrepancy of the data. We have those ever registered and beautiful, but the 78,000 are only the ones that if they have been retained in the register, because some of them, when they come, for example, to the US, they don't need to renew their license, which means that we have somehow lost them within our tracking, though they may be able to come back to that. And our annual production is 5,000 to 6,000 per year within those who come to the register for the council. But if you see the national average and the distributions of the numbers, our UAC target is 1 nurse to 300, and we are at almost double, like one serving 775. So just appreciate you that we still have a need gap of over 4,000 additional nurses for us even to meet the global standards in the next 4 years, because 2030 is in the next 4 years. So again, this is the map of the Kenya, also appreciating their distribution, their density, and we have all the ASAL region, the arid to semi-arid regions, where the concentration of our nurses and the entire health workforce measured in the big cities, and we have less within the other places that they are there. So the nursing workforce trends just comes from the issues that we discussed with the policy reform, where our country started to be able to improve and do a lot of investment in nursing in the training facilities, increasing the numbers who are trained across the country, which we've been able to see it's actually doubled the last 5 years. Then again, something came up in the immigration spike post-COVID and even before COVID. And we started now having a spike of the nurses for immigrations because a lot of opportunities came up, a lot of awareness came up, a lot of people that they are recruiting, I worked with the agencies for the recruitment, having their business models and all those things, and a lot from 2017. It's really opened up and a lot of nurses were able to do that. The pandemic impact again came where it was now critical. There was a lot of awareness in our country, especially when the nurses started now realizing that their role is critical, everywhere during COVID, and it was that awakening and that COVID-19 pandemic response led now to a lot of demands in the healthcare systems. The rural retention also declined because people started going to the cities, and again, there's also issues of unrest within the employment. Most of the time, because of different governance structures, the resource envelope for the finances is smaller, and most of the time that the healthcare personnel actually go strike. It was really difficult moments during COVID when we had our nurses and even our doctors. I think they went for strike. Julia, that must have been like around 100 days, and it was so hard for us. So a lot of those strikes and protests are coming, and this is the trends that we are able to see that we might not be able to retain that. So the gap is still there. We still have insufficient training capacity. But again, when we say insufficient, it's not that we have the resources to double. We do not have the clinical placement sites. We don't have enough faculty to be able to support them. So as much as we don't say insufficient, is because if we see the projections, we need to be able to put a lot of investment, and we cannot double the numbers because again, we'll be able to water in the quality. So attrition factors are also coming there. Over 2,000 nurses are retiring. There are over 800 to 1,200 nurses per year are also immigrating, and others changes career, others decided to pursue other things in their life. So that is where we are. This is something that when we have conversations on immigration, we ask ourselves, where are these nurses going? And I understand every time I travel to all these countries, I understand the push and the pull factors why they want to immigrate, better working facilities and that. And as I was mentioning earlier, I had an opportunity on Monday to go to the Children's Hospital. And if I was a little bit younger years, maybe 22, I will for sure stick around. Yeah, this is just because the age is a bit advanced now. And I do understand why they come here, because this different system, opportunities and different perspective and their value chain when they reflect on who they are and who they are as to provide them here. So in the last 3 months, the 1,824 nurses have expressed interest to immigrate. So we don't have the actual nurses who migrate, but these are those who are immigrants. And we see the beautiful countries with the flags from, starting with you people, America, Canada, Australia, and also the UK. And 89 of these have moved to the US. What is quite interesting is even when these nurses go to the UK with the NHS, they find their way back to the America. So they will start perhaps with the UK, and then they finally cross over. I'm not quite sure about the Canada, but I know a lot of colleagues who have been able to do that. So there's something that this country is able to attract them, or rather be able to provide those opportunities for them to come here. But even as much as we immigrants who we provide the exports, there's also issues that I'm able to share shortly about our fragile health systems, which is something that when I supported the Ministry of Health, my ministry and my country during COVID, and we went to all counties in Kenya, from the cities to the towns to the remote places, because we wanted to see the preparedness. It was very, very disturbing for me to be able to see other places that you go, you have carried the equipment during the COVID, the critical care and all that thing, and you find that they are in stores because we don't have the personnel. And the medical team who are there, they don't want to go there because if they contract COVID, they don't have advanced medical support to be able to support them. So there's a lot of inequalities, there's issues of access, there's the intention, there's the goodwill by the government, but now the workforce itself is something that we need to be able to think so. So these are part of push and pull factors why they want to immigrate, difficult working conditions. There are places that they have difficult working conditions. I worked myself in the clinicals, but I worked in large hospitals. But there are places where it is difficult. The nurse is everything. The nurse is caretaker, from the watchman opening the gate, the nurse is the cleaner, the nurse is the records keeper, the pharmacist, the doctor, the referral, sometimes even supporting as part of the ambulance. If you have a car, the woman is bleeding. So it is difficult. I say that those are people who serve humanity for real, and they are there. And we've seen a lot of success stories on the social impact. Lack of recognitions, I say post-COVID, it is good, but most of the time, we express that they don't have recognitions, economic issues, limited career advancements, opportunities, and even in regards of the tough economical issues. Most of the people that they immigrate at the moment are those that perhaps their children wants to get a better education, they want to advance in their career and all that. So that is what it is compound. Part of the pull factors, working conditions, career advancement, employed remunerations, which is relative because the word improved, again, the cost of living in all these places is also high. So it's really like something which is a relative term, but most of the people have reported improved remuneration, which I do agree. If you see the Kenyan shillings versus the dollar versus the pound, it is a whole different dynamic. Again, the improved personnel and national economic condition is part of the pull factors why our nurses do that. So we have policy gaps from labor immigration policies and guidelines, issues of the brain drain, ethical recruitment. Most of the recruitment are legal, but they are not ethical. So those are some of the policy gaps that we also be able to experience, and even lack of our policies of reintegration. For example, Edna, I come here, I finish my tour of work, in another 15 years, I want to go back to my country to serve. There's no reintegration. The last time I left my job, someone was replaced immediately. So when I go back, I don't have place to be able to do that. And I'm going back with a lot of expertise, and I just want to go and give back to the community. So issues of training institutions not complying with some of the standards, as an African region and even within the East Africa, we haven't been able to even harmonize our requirements across, even for colleagues that you've been in Tanzania, some people who've been in Uganda, we need to be able to harmonize for the free labor markets. Again, implementation of career progression guidelines, and some of the time we have conflicting mandates. When access leave, issues that we've discussed, poor working conditions, we have the workload, inadequate resources, low compensation, safety concern for people who work in the insecurity regions, and also limited career progression. Some really wants to be able to study, but there are not those opportunities. We don't have a lot of e-learning models. They do not have the required infrastructure, the internet issues, and they are so tired. You know, we don't have a system where you can be able to support those. Some of them have been able to manage, but again, they are not able to. You know, the systems are a bit complex for them to be able to manage the tasks. And again, being from our community, you raise a community. Most of the time when you go to school and you get a job, you go back to raise a community. So it's not about your nuclear family, it's about your extended family. If you are married, you're taking care of your parents and your in-laws, you have kids to do. So a lot of things which really come up in that limited space for them to be able to do that. So rural deployment and retention is also another conversation, and it is a bit tougher in regards to professional isolation. Sometimes you are alone. I've met nurses alone, you know, in there are no skills, it's no people to be able to talk to, limited educational opportunities if you're working in areas where there's no electricity, internet. So you feel professionally isolated, and sometimes that they don't want to work in such areas. Again, clinical skills, which sometimes needs to be able to be refreshed, infrastructure gaps. As I mentioned, I worked in some of the hospitals, but then our infrastructure is so constrained. You know, patient sharing space, you know, facilities to be able to support them, and it is worse in the rural setup. And then other things as family and social factors. You want to raise a family, you went to school, and you want now to move to the cities where your children need to get better educations, or you are married, like myself. When I got married, I moved to the city because I wanted to join my husband and the family. So I can relate on this family and social factors that it removes you from where you just want to work and where you want to be able to raise your family. And all these are what we are seeing as part of the rural and retention facilities. From security concerns, there are places that we still have a bit of banditry in the regions, long distance to facilities without transport, issues of the insecurity. But could you believe that they still work in this, irrespective of all our retention issues? Our nurses are still able, you can still meet them in these facilities, and they are working and they're able to support the communities, and of course the financial strain which comes from them. Then I have discussed about the entire Africa. I've discussed about Kenya. I've discussed about the challenges. Who will be able to resolve this work? Who is able to resolve these concerns there? And this is where there's the advanced practice nursing context in Kenya. And in 2019, and I'm glad that I was part of the process of reviewing the Nurses and Midwife Acts, we noted that we needed to be able to have the advanced practice nurses as part of the specialization. The reason is that when we go to our communities, the level 1, level 2, and level 3, which I showed in a previous slide, we have limited skills mix. We can have maybe one clinical officer. At the moment, at least we have one medical doctor who sometimes will be able to handle advanced cases, but the whole populations, we don't have anyone to be able to support them. Of course, the nurses are there, but the nurses who are there have limited competencies because they are enrolled practice nurses. And it was designed in a manner that when you treat malaria in health center, perhaps you need to refer to the national referral. But the same human being or the same Edna, the same malaria treatment I need to get in health center is the same malaria treatment I need to be able to get in another hospital. The same pregnancy, when I just work with an health center, is the same service and same advisory that I need to be able to get in our other private hospitals. So because care is care, and we do not want to be able to have delays, the delays models in getting treatment, healthcare professionals to be able to think through. So at the moment, we have only 3 universities which offer advanced practice nurses, and we have 66 advanced practice nurses, and most of them have been able to be trained in Kenya, but majority trained in South Africa, because I think that of Cape Town was part of the first universities that they started teaching the advanced practice nursing, and this will be able to support our fragile health system. So the advanced practice nursing readiness assessment report, which I will be able to take you through, is what we said. Yes, we've been able to train them, but is our country ready for the advanced practice nursing? Are we ready? And in that conversation, we engaged and we assessed, and we got this a bit of funding from TET, formerly called TET, which is Global Workforce at the moment. And for this funding, we worked also with Ghana. And we went to the training facilities to be able to examine the capacity for them to train. We check on our county governments for them to also assess the capacity, the regulatory body and Ministry of Health to assess the policy and regulations, and the clinical placement sites to be able to evaluate, are APN able to be mentored? Are they able to be placed? So we utilize the capability maturity model to assess the institutional readiness across the training institutions, the clinical placement, regulatory systems, and the policy preparedness. Are our people ready to be able to employ them? Because we can be training and the government is not ready. The leadership is not ready. The director for nursing services has no idea what is advanced practice nursing, because perhaps she did masters in public health. The workforce integration preparedness, is our workforce, is our medical doctors ready to be able to work with them? Because it's not role substitution, but it is like we need to be able to work together in that. So with that, it was amazing to be able to see part of the results from the training institutions. We just noted that, yes, some of the facilities are ready. We check on the research, we check on the clinical placement sites, we check on the curriculum designs. And from a score of 0 to 5, where 5 is advanced, we actually noted that it was only library and the research and also the curriculum design was the one which had been able to be worked on. On the clinical placements and mentorship side, it was only the clinical sites which they were ready, but overall score was still yes. We still have issues on the mentorship gaps, the clinical sites not very ready, the quality and the safety, and also the research and education. And these are part of the conversations we did. So I was part of the team that they went and assessed, and for colleagues who've been in Kenya and supported the APN from the Center of the Global Health, you can be able to see the chief nurse for no referral in the slide, which we are able to discuss, and we'll discuss the scope of practice. This is the scope of the nurses. This is the job descriptions. How much are you paying them? And it was a good conversations, because we were asking, how do we be able to measure what are the metrics of patients' outcome and improvement of the care and equal remunerations? And we met all the management teams, the human resources, and we had a wonderful conversations over that. So for the regulatory systems and policy preparedness, yes, at the national policy, we had a good policy for nurses and midwife policy. But at the implementation, we still don't have the register. We still need to also to be able to work on other accreditation of the program. On the workforce integration and preparedness, again, we were also able to see also some of the gaps in regards of the data, the deployment policies, like if, and one of the chief executive officer told me that, Edna, if you send me this advanced practice nurse, for example, nurse anesthetist, and I have the medical doctor, anesthetist, and the clinical officer, where do I place, And this is a CEO of an hospital and human resources for health advisory, and the people that they employ, they were not aware, and they didn't know where to be able to fit. So a lot of work needs to be done, even as we talk about this advanced practice nursing. So overall score, the training seems to be doing well, but a lot of things needs to be worked on the policy levels, on the integration, and also on the clinical placement, because the training is something else. integration is something else, the deployment is something else, and working as a team is also something we need to be able to do that. Within the same project, we worked on the clinical leadership and be able to also to pick it up. Then we realized, because we took a bit of time to even agree what is APN, because other people were able to define differently, they had different perspective. And we came up now with a clinical leadership, and we picked the chief nursing officers, the nurse in charges of the units. We pick the people in the academia were having different conversations, and also we pick our associations, people that they are able to advocate for the profession and the regulatory body. And we call it quad because they are 4 in 1. And we had this conversation on the clinical leadership, and we had a whole webinars for the last 6 months. And I say that if we go back again for the second assessment, perhaps the reception within the nurses themselves has improved because we had that conversations over that. So these are the webinar series on professional leadership, the policy, health systems, and also patient-focused leadership, because we need the clinical leadership to be able to support the advanced practice nurses. And these are part of the amazing work that we've done with the UCSF, Center for Global Nursing Advisory. You can see Natasha in one of our meetings that we came up with the educators, the Ministry of Health, the regulatory bodies, and the nurses themselves in one of the hospitals, which the center supports in the clinical leadership. And we also have the university, one of our universities, and a lot of engagement that we were able to have. And that is the CEO for Nursing Council, discussing about the scope, because we've developed the training and we've developed the scope, and we need to be able to have that conversation. So it was very nice engaging and having different perspective on what does the APN looks like. Amazing to just understand what Rebecca and the other APNs, amazing APNs here are, and what they are doing. We had conversation with our medical doctors. How do we share that space? How do we share patients' work? And we realize that there is enough for everyone. We just need to be able to come together and do the collaborations. So it was very amazing to be able to have that interaction with the team. So we had key gaps in implementing APN, the lack of standardized curriculum. The 3 universities were using different curriculums. What does that mean? We'll have different competencies at the end of it. So we needed to be able to just have a standardized curriculum, ambiguity of APN definitions. There's the APN, there's the CNS, the clinical nurse specialist, there's the general other masters. So there was a lot of ambiguity in those, lack of clear career guidelines, even from the employers, mentorship, and all those. And we came up with a lot of recommendations on work that we need to be able to do, especially enhancing the stakeholders collaboration, the funding, the needs assessment, and recognitions and mechanism for them, because at the moment we have lost some of the advanced practice nurses. They have immigrated because they got the skill, they went to the clinical. It was hard or perhaps difficult, to be able to work in that space, lack of remunerations. And the nursing is very, very expensive in Kenya, training and putting all your energy. So there's return of investment. I always say that as much as we provide care, there should be return of investment, because if what you've invested, you should also be able to give it back. And we also had a discussion of what is this implication to the Kenya health systems now. The implication is that we need to strengthen. But we need to strengthen because we have trained, we have these policies, and now we have this space for the implementation. So we need to start that conversations on deploying them and having proper deployment, proper remunerations for them, professional development. So we are talking with our medical teams, and we have one of our amazing center in Moi Teaching and Referral Hospital, where they are able to work as a team. And during the 100 days of the strike for the medical doctors, they were able to see the gains for the APS, because then they were the nurse consultants, especially in the pediatric critical care units, even in the ICU, they really stood up, in that period when our medical doctors just step aside and they say this. So that is where now they actually add a reflection that they can be able to work together. And when we have our residence doctors working their masters, they're happy because their shift is so long. So they are happy to hand over to an APN in the morning for them to go and get the rest, and then they can be able to get the feedback, and there's the continuity of the work. So these are part of the action plan. We need to develop co-curriculum, clarification of their roles, the compensation mechanism, clinical leadership and advocacy, and moving there. And also just wrapping all that conversation is that we still need the global health leadership. We need the leadership to be able to drive this agenda. And in this, just to be able to summarize the work that I've been supporting with the Global Nursing Leadership, the UCSF Center for Global Nursing, the Global Nursing Leadership Institute with the International Council for Nurses, which I do support, and the ODENNA Project that we oversee the 23 African countries. And all this, we are just saying, yes, we are leaders. When you are given the space, when you are meeting the parliament team, the treasury, where the money is, meeting the cabinet secretary, how do you pitch for the money? We teach them who do you recognize, because everything is politics. Our landscape, monies are provided using the political language. Even doing the message triangle, how do you pitch when you are elevator pitch? How do you become concise? How do we speak up? How do you negotiate with that? So all these are able to really help us even in the clinical leadership, in the clinical space, to be able to advocate that. So this is capacity building for the health systems, advocacy, how do you influence the policy, competency-based, action-oriented, doing a lot of research and the publications, and also having the global local nexus, where we need to be able to translate the global frameworks to locally relevant and being sustainable, because the APN in UCSF hospitals, the work they do is very different with the APN in our local context. So we just need also to be able to borrow and be able to see how do we be able to support us as we move on. So as I conclude, these are amazing global leaders that we have. And when we talk about impacting, yes, it is because when nurses wants to go to strike, who is that calling for the strike? It is the professional association or the union. Does that leader understand, do we go for strike or is there better negotiations model? So we come and we say, hang on, before you tell people to go to the street, have we met the Minister of Health? Have we met the treasurer, principal secretary? Have we sent a message to even the president through the advisory bodies and all that thing? So it really helps us, and we were able to just check from all the trainings we did in Rwanda, in Kenya, the GNLI sessions that they have in Geneva. We realized that we are a whole global communities, and our challenges are not the same, but they are similar as we work across that. So we want to just say we need to own our leadership, we need to mentor our young nurses, advocate, build coalitions, do the innovations, and even beyond that, we'll be able to see the triple effects. One leader can create hundreds. When one nurse completes the Global Nursing Leadership Institute and our certificate for that, they're able to train additional nurses, they're able to influence the policy, they're able to do the mentor. And we even say to influence, it is even influencing the resources in the world. I do remember when I work in the maternity, I needed also to advocate for the little resources, including the theater table. You understand how you need actually to be able to navigate and also negotiate for those limited resources. So we need to be able to continue having that ripple effect. When one nurse becomes an advanced practice nursing, they're able to provide 1,000 care to 1,000 population on there and disturb patients. We are able to discuss and have different models of an advanced practice for the peers, and again advocating for scope expansion, of course having in mind that they should be able to have the right competencies. You cannot expand something. So again, how do we have accreditations? How do we be able to have these certifications and certification programs that they will be able to build on the work that they're already doing? And finally, when one nurse leads an NCD program, they are able to save numbers and many patients, educate the patients, and we need to be able to shift the care from the reactive, the curative, to the preventive models. And having said that, the future of nursing is within us. We need us to reflect today how we'll be able to step up, who will be able to mentor, who will be able to advocate, and who will be able to innovate. So the potentials, opportunities as I finalize, is that we have a lot. We have a lot to work together. I can see brilliant minds here. I can see beautiful pieces of work that you can be able to bring together and build, even on basic things like NPN role clarity, and how do we integrate on the programs to develop the clinical leadership, the regulatory guidelines. And why I mention the clinical leadership is because I've been in the big boardrooms in leadership, but when you go to the clinical area, it's very different. We just need to go in that space and just say, what is it that we need to be able to advocate for better patients' outcomes. We need to also be able to have opportunities for joint research. When we go to International Council for Nurses and some of the conferences, I and Rebecca, we've gone for the APA and the upcoming one in the US, we don't see the voices of our work that we've been able to do in the Africa region. We really request you to just hold our hands for joint research, for the implementation research that we can be able to publish and have evidence to be able to advocate. And finally, the bidirectional learning. It's very amazing to be able to have this bidirectional learning. We learn from you, you learn from us, and we are able to co-create the content that fits every local situations. With all those, I just want to say thank you so much. And in my Swahili, I think for this time, God bless you.
I mean, she's amazing, right? Yeah. I think when you think about Edna's career, yeah, I can hear. There, I took care of it. Sorry, that echo. When you think of Edna and you think of what she's done, expanding nursing in its scope, expanding and thinking outside the box, and welcoming advanced practice nursing to her country to help work for creating regulation, training nursing leaders so that they have a voice. In healthcare and in healthcare systems, we know nurses make up majority of the global workforce. Most of them are not prepared to have a conversation with a medical doctor or with the CEO of the hospital, but how can they be prepared because they know a lot? And so thank you so much for your work in advocacy and leadership. I want to open it up because I know we just have a few minutes. If anybody has any questions for Dr. Slem. Herba, yes.
Thank you, amazing presentation. A couple of questions. One is this similar to the nurse practitioner kind of role here? Okay. And then does the government of Kenya actually recognize this as a specific cadre on the, the government sort of employment? I forget what it's called.
The career progression.
Yeah, so is that recognized? And then the other thing is, do your nurses go to other countries in the South? Or do they tend to just come to the US and the UK? Or is there
For immigration or for learning?
Migration,
Okay.
like South, yeah.
All right, quick one. Yes, it is your NPs, your nurse practitioners. In regards of the employment, the good thing is that when I served in the council, my chair was a professor of Aga Khan University, and we got funding from J&J to be able to do 4 things. The first one, we gave the money to the nursing council to develop the scope of practice. We gave the money to the chief nursing officer to develop a career progression guideline scheme of service. We gave the money to the associations to be able to develop the strategic plan and voice for the nurses. And finally, there was also funding for the training institutions. So when we were launching the scheme, the scope of practice, we were also advocating for the scheme of service, which was that career progression. So it was a beautiful place that it was worked together. In regards of that, it's only few that they go to South Africa, but mostly they go to study, and a few of them have been able to be retained. So within the Africa, we only had an agreement with Namibia, but at the moment, the country that I can think of is only South Africa. Yes, but some even from South Africa, they find their way.
And I just want to add that for those of us in the US and the DILIS, the advanced practice nursing, as we define it, could be a nurse midwife, a nurse practitioner, or a nurse anesthetist. At UCSF, we also have physician assistants, and that's what we call APPs, is all of those together. We, in the United States, say that advanced practice nursing nurse practitioners were founded in the United States in the 60s, and I just want to be very clear that that's absolutely not the case, and that nurse practitioners have existed for many, many centuries across the world, particularly in countries where they have been prescribing and managing care for a very long time. And I think your work is really to say, wow, this has been happening and it's regulated other places, and nurses have the education that matches what they're doing, which matches their training. There are so many studies that we know about where nurses are doing things that they weren't trained to do. And we're like, how can, Edna's question, right? How can we prepare the workforce to do the work and support them doing it well? And I think that's what's happening now. In your area and in the area of a lot of our colleagues, is they're formalizing this and trying to find a way to support nurses that are in rural areas, prescribing and managing hypertension every single day, and then maybe don't have and just have an RN license. So I think just so that everybody knows our context is that this is not new, but it is now being formalized in a really important way to support the development. Phyllis.
Yeah, that kind of helps clarify a bit my question, but the whole issue of nursing and midwifery, I know the midwifery world has been making a big movement for independently certified midwives. And I noticed in some of your slides, it was nursing, and in others, it was nursing and midwifery, and the numbers, does that midwives? And is there any sort of collaboration or even tension between the nursing council, and is there a midwifery
That's a good
council?
question.
Yes, well done. So we train nurse midwife in 4 competencies: general nursing, midwifery, mental health, and community health. So like myself for my bachelor's, I am a nurse midwife because I had both competencies. However, there's conversations because we have ICM and ICM, International Midwifery. So we are Bachelor of Science in Nursing and we are Bachelor of Science in Midwifery, which is still a new role. Remember, initially in many years back in 1980s, we used to have a midwife and a nurse. But later, the government say that we have shortage. How do we have one nurse to be able to support in 3 components? That's actually how we manage. Now we are going back again. But there's a lot of conversations and we've never agreed. Because when I stand, I'm like, I as Edna, I'm a nurse midwife, I've delivered women. What is it that you think that I don't know? Then the midwife say, no, you don't have the competencies as per the ICM. You know, the competencies that you need to be able to work on that. The good thing, when I saw that and I was a CEO, I rushed and I broke the act. So the act is called Nurses and Midwives Act because the midwife wanted to have the act. So they can't have their own. So we are locked together in the meantime. The good thing, we have the Association for the Midwives and Association for the Nurses. Yes.
And at WHO,
Yes.
they're together.
Yeah.
So Amelia is in charge of both.
Yes.
Yeah.
So in the numbers, there are both numbers for nurses and midwives. Yes. But I can provide separate numbers for the midwives alone.
Your address.
Yeah. Well done, Edna. I'm always proud of nurses from our context, Africa. So I think you've done a very good job. I do have 2 questions. Number one, career progression for whether you want nurses or midwives or combined. Because what we saw in Malawi is at the moment we started working on career progression and giving opportunities for nurses and midwives to do their masters, and we actually developed programs in those areas with the childhood nursing. You know, the issue of nurses leaving Malawi started slowing down, and I noted that in the last decade that most of our nurses wanted to stay home because they were able to do many other things. So I wanted just to find out whether it's just always been pushing for the clinical, side, or you're also looking at internal migration, because some of these nurses remain in African countries, but they're working for UNICEF, they're working for, UNFPA, and many times we ignore that group, and they are also making a difference. So I wanted just to hear how you looked at this matter in Kenya in terms of, are we giving opportunities for nurses to buy bread within our countries so they can still go to the ward and yet hold a PhD? So I think to me, that's what I would like, because you cannot say stay here when there are no opportunities.
Yeah, absolutely. Thank you so much, Prof. Morata. It's always amazing. You know, Malawi and Kenya, we are very good friends and we are just neighbors. It's just Tanzania who just decided to cut us across. So quick one, for the career progressions, unfortunately, we don't have the DNP. We are PhD. And with the growing training institutions, there's a lot of huge demand. And because the nurses felt they were not appreciated in the clinicals, the early they finish their masters, the early they leave clinical like a tsunami and they go to the academia. So we need now to bring them back. But we have nurses in most of our major hospitals who also have masters and have specializations. And if you ask me, I'm in academia, clinical space better. If I see how I was used to be paid and now, yeah, so I was even thinking I need to go back to the clinical. So yeah, you are right. So yeah, but the good thing again with the clinical and career progressions, they are promoted more than the promotion you get in university. You know, university, senior lecturer, professor, you understand? So there's a bit of motivation in the clinical. So some of them are going back to the clinicals. Yes. I hope that answers you. Yes, but it's still our conversations.
Always so great to hear you talk. I had a question about economic feasibility for people tuition and what resources or what is the realistic approach for somebody to progress their education as a nurse, and are there loans, or what is the likelihood of them paying that off as they further their career once they leave their training and go back to their new role?
The good thing, actually, nurses, if you have a diploma course in Kenya, the nursing is the most paid profession. You will not even, they even paid with more than lawyers, more than engineers who are actually entering the practice. So, and then we are part-time work. So nurses actually are able to make a little bit more. So there are loans that they can be able to take, and the opportunities are there. It's just because the balance now, as you'll be able to move, you know, towards meeting your needs. But opportunities are there. We have loans that they can be able to get them, to repay them, and some of our nurses can even make extra money because they are able to work on shifts and move. But then that only happens in the cities, not within the rural facilities.
So in returning back to progress their education, they have the opportunity financially because they have them themselves.
Yes, and again, sometimes 10 years ago, we also introduced virtual blended courses and workplace, which really helped them. So they are able to go to the evening classes and that. And the good thing is that you can progress from certificate to the PhD. So once you have the diploma, there's some courses that we exempt. So the career progression is okay, just because we need to combine many things. Yes.
I can. Oh, wait, I thought there was a mic. Sorry.
I wish.
So I come from Kenya. Thank you for a very good talk.
Yeah.
Very excited to find a Kenyan doing a good talk here. This is my question is as a Kenyan, I know that the government invests in the training of nurses. At the university level, the government actually sponsor those nurses to go through the training. And most of them, when after the training, they run away to other countries like the US. What would be the solution for the government of Kenya to maintain this nursing based on their own experience, either from the government of Kenya,
Yes.
but how about institutions like UCSF?
Yes.
How can they support the government of Kenya to ensure that the nurses who are in Kenya remain?
All right. Yeah. Good question. Good question. So in the presidential task force that I served as a joint secretary, we were discussing issues of human resources for health. So the president did the task force, Julius, you're aware, and we actually came and we decided, actually, we found that nurses are paid more among even our African countries, to be able to say. So that was a good recognition. In also the government pays more than the private sector. So we did that analysis and we have our own report that we'll be able to share. So first thing, nurses are not aware about that. They every time they're in a ward, they'll compare themselves to the medical doctor. And I tell them, don't compare yourself with the medical doctor. Compare yourself to the peers of other professions. Compare to yourself with a teacher. Compare yourself. It's just because there's other opportunities. So first, the conversation is for the nurses themselves to realize and acknowledge their role. The second is our government to see that they support them in regards of the retaining them, the motivations. So that needs that conversations. And of course, finally, for the UCSF, its colleagues, we work together. And also working especially on research, publishing the data, opportunities to be able to share that, part of other intrinsic factors and motivations that perhaps they're not available in our local setting. But our nurses pretty much are fairly okay. Yes. Compared to other Kenyans.
Thank you so much, Dr. Tallam, for joining us today.